When we're at the hospital, there's a command system we use. Typically, we need to identify our hospital incident commander. This is the administrator of overall leadership that implements the plan. Nurses who are working during a multi or mass casualty, they need to check in and out at the command center, and they will have the accessible communication technology set up there. When we're talking about the hospital incident commander, it's usually an ER physician or a hospital administrator. It's to take a global view of the entire situation and facilitate patient movement throughout the system. So if we knew there's a true trauma and coming into the hospital, and we know that stuff is coming, we need to come up with a plan on how we can handle this. Also, we're going to have a medical command physician, the physician who decides the number, acuity, and resources needed for each patient, and how many patients we can take during this true mass or multi-casualty, or if we need to divert patients to Blessing or somewhere else. There's also the triage officer, and can be a physician or a nurse who rapidly evaluates each patient to determine prioritize the treatment needed. So if they're having chest pain, we're going to do EKG, labs, chest x-ray. And mainly we need to know, the role of the nurse during all of this. Well, if we know a disaster is coming in, we need to have our plan ready and review it quickly. We may need to call other nurses and staff in. If patients are in the inpatient side of nursing and we know there's a true trauma coming, we need to identify what patients can be discharged as soon as possible to free up beds. We need to treat and release any patients that are in the emergency department. The emergency department charge nurse will delegate to ER nurses. The ER nurses will deal with a mass casualty and any extra staff that might be brought from like the ICU, med surgeon, OB. They're going to take care of the patients that are stable in the emergency department. We know that med surg 1 nurses can handle abdominal pain, so we'll assign them. If we have a PCU nurse, we may assign them to take care of a patient with chest pain that's not having a STEMI. Nurses should have everything ready, and in our homes, we need to have assembled a readiness supply bag for home or our automobile with clothing and basic survival supplies for up to 3 days. This would be double important to have in case a disaster requires you to evacuate your home. Patients that, if we're on the if we are in the inpatient side of nursing, patients that can be discharged early may be patients who are admitted for observation and are not bedridden, are having diagnostic evaluations, are soon scheduled to be discharged, and could be cared for at home with support from family or home health, have had no critical changes in the past 3 days, or could be cared for at another healthcare facility, such as a rehab or long-term care facility. At the staff, we recruited extra staff, I said. And at the end, when this is all over, some nurses may experience ethical and moral conflict among their own personal preparedness for disaster response, family obligations, and professional responsibility. The ANA Code of Ethics offers general statements and guidance that can help nurses. Each person has to make a personal choice about whether to be involved in helping during an emergency or when to become involved. At the end of all this, we need to decide when the last major casualties have been treated and no more are expected to arrive, we can begin to have a stand down or deactivate the emergency response plan. Although people may have been left in the ED to be cared for, the hospital may resume normal activity. We need to make sure that all hospital departments have been met and all are in agreement to resume normal operations. During this, severe shortage of supplies may become a threat to usual operations. This will probably happen with COVID-19. We need to take consistent inventory and restock as needed our high priority assignments at the end of a multi or mass casualty. You need to communicate with your central supply department. Then there are two types of debriefing. At the end, one component is a critical incident stress management program. This allows, after, sometimes in the emergency department, if a death goes wrong, we'll have a little, I want to call it a chit chat, but it's not a chit chat. Just to talk about your feelings and see what could have, maybe something could have changed to have a different impact, but just the emotional impact of the incident and the aftermath. And staff may have problems returning to normal. They can also experience post-traumatic stress disorder. You don't want to have nurses feel burnt out. Another type of debriefing is an administrative review, and this analyzes how the hospital responded to an event while it is still in the forefront of the minds of everyone who participated in it. So we're always, if there was a true bus accident and we treated it all and we followed our plans perfectly to a T, then administration looks and says, okay, this went good, this went good. Oh, but that, our walking wounded or the green tag patients, they really got kind of neglected, so we need to beef that up. And we're in the community working as nurses, so we're walking along and we see that nurses may need to be out in the community responding. There's a paramedic from Monroe City that's responded to COVID-19 out in New York City. So the first action as first responders in a disaster is to remove the people from danger, both the injured and uninjured. Firefighters and other disaster training emergency personnel can help with this. Victims are then triaged by healthcare personnel, and we provide on-site aid and emergency care, and we want to help educate. We need to educate patients that there's shelter available and how to live temporarily in shelters, like if a tornado hit. How are they going to get clean drinking water? It may not be able to be available for days, so they may need to boil water before drinking. And then, like in Hurricane Katrina, this is a picture from it down here below, or it might be. Actually, I don't really know, but I'm going to assume it's in it. Human waste management creates another challenge if toilets don't flush. So it creates risk for pathogens to grow and spread disease. So you may need to make sure you're cleaning with bleach and other alternatives that could be available. And then the psychosocial response of survivors. When I think with the COVID-19, patients are dying alone or with no family at the bedside. Yeah, we can say FaceTime's a great thing, but really is it? Changes in visitations and funeral. No gatherings greater than 10. So we need to be able to help. Nurses need to help provide the ability for family to cope. I know in the emergency department we have a family room, but that's only going to hold probably one family, maybe two. And what about the psychosocial response of the survivors? Disaster experience can produce immediate and long-lasting effects. Lifestyles, roles, and routines may be altered. I think you all know I went to Las Vegas over spring break and just relaxed by the pool. Saw a couple shows. Those hotels closed like 4 days after we left. So they closed March 15th. And they're going to be closed till May 1st at the minimum. All of the jobs in the hotel, the cleaning people, the servers in the casinos, the shows that are held at all these hotels, people making your breakfast, checking you in, checking you out, door greeters. So their lifestyle and routine is changing. how do you cope with the stress? How do you cope with being not inside, but not around your family? I talk to my mom every day now. I either call her on the phone or FaceTime her. Not that I'm a survivor, but like, what if she gets admitted to the hospital and I never see her again? They literally drove half an hour to come see me on Easter. We sat outside for half an hour, then they drove home. We stayed 6 feet apart. Survivors have to confront their own feelings of vulnerability results from devastating events. They need to realize it could happen again. The nurse taking care of the patient needs to remain calm and reassuring. We can ask for crisis counselors. There's a questionnaire you can use to assess survivor response to disaster. It's called an IESR questionnaire. All right, some participation questions. The Weather Center has issued a hurricane warning. What type of disaster warning does the nurse anticipate will be activated? C, an external disaster. Question number 2. An emergency nurse is performing disaster triage following the crash of a 737 jetliner. Which patient does the nurse assign a black tag? A 26-year-old that's confused yet ambulatory? Probably not. That might be a red tag. 40-year-old with an open femur fracture? That's probably a yellow tag. Hopefully she's got a pulse. But don't read into it. Just assume she does. Just says open femur fracture. A 54-year-old with facial lacerations? That's probably a green tag. Or a 42-year-old with full thickness burns to torso and extremities. So a black tag, D. Typical examples of black tag patients are those with massive head trauma, extensive full thickness burns, and high cervical spinal injuries. You must be dedicated to saving the most lives rather than expending valuable resources to save ones at the possible expense of many others. An ER nurse informs the charge nurse that he can't sleep or eat after providing care for school shooting victims last week. What is the appropriate charge nurse response? A, I know how hard it is, but the memories will fade eventually. Probably not very compassionate. You look stressed. If you take a few days off, I'll cover your shifts. Well, that's great, but that's still not going to help him cope. We have to be stronger than that. We will see disasters all the time. I really don't like to see disasters. Or D, the occupational nurse can help you explore critical incident stress debriefing options. Obviously, the answer is D. All right, so we talked about pandemics. We talked about COVID-19. It's here. We're living it right now in 2020 when this is recorded. You know, patients may experience post-traumatic stress after this. So when the nurse is taking care of patients on a COVID unit, what can we do during them to help prevent post-traumatic stress disorder? Well, we could make sure we're giving them breaks, making sure they're eating. If we're going to do some mass casualty, who are we going to give a red tag to? Maybe somebody that's short of breath. Maybe somebody that says they're having chest pain. Who are we going to give a yellow tag to? Somebody with an open fracture, abdominal pain. They can wait 30 minutes to 2 hours to be seen. Who are we going to give a green tag to? Somebody maybe that has a closed fracture to the right clavicle. That also could go with yellow, so it's kind of yellow to green. What about somebody that just has a bruise on their forehead? They're alert and oriented, they're talking, they're 25 years old. It's probably a green tag. What if somebody has a cervical injury? They were the bus driver and they hit the train head on. Bam! They have a cervical injury, so that would probably be a black tag. What's the role of the charge nurse during mass casualties? They're going to direct med-surg and critical care nurses to assist with patients currently in the ED, while emergency staff provides care for the mass casualty victims. So we're going to give those nurses patients who they know how to take care of. Oops. I got click happy. We're going to do some community-wide preparedness. Go back to that. We want to use care for the greater good. When we're doing the event resolution, we need to communicate what happened, what went good and bad. If family feels overwhelmed, what's the nurse going to do? We're going to provide a calm location for family to cope. The role of the nurse. We also need to know who we can transfer or discharge outside of the hospital. So be aware of that. The hospital needs to be prepared and have these practice roles. They're going to identify a hospital incident commander who assumes leadership for implementing the hospital emergency plan. We're also going to have a physician identified, and we're going to have a triage officer who rapidly evaluates each patient to determine priorities for treatment. Alrighty, if you have any questions about Chapter 10 and you watch those videos, you let me know. Good luck on the exam.